Hello, this is ECG case number 10. Let's get started and take a look at the case scenario. You respond to a 60-year-old male. He's got substernal chest pain. He tells you it radiates to his jaw, and nothing makes this pain any better. It feels like it's squeezing, and it's a 10 out of 10. All right, so you need to think about this presentation. It's an elderly male. He's definitely within the realm of cardiac disease. He has severe squeezing pain that radiates to his jaw. That's all cardiac-like symptoms. And he tells you it's a 10 out of 10 and nothing makes it any better. So you've got to narrow in on cardiac right now. And one of the things we do is obtain the 12-lead EKG. So here's the 12 lead that goes along with this patient. All right. I didn't present this initially with all of these findings up here where it says acute MI and everything, because this 12 lead does look like something else alone. If you take away the patient presentation, okay, this 12 lead might indicate something else. Let's look at it. The big two things that everybody mentioned on the Facebook site when I presented this case was either pericarditis or acute MI. Pericarditis or acute MI. And I understand why you would think either one of those. So let's look at this EKG and see, what the indicators are. Again, we said it was a 60-year-old male. The rhythm, it looks to be sinus, although there is a little bit of an irregularity. You have right here, you have a regular interval there, and then a little bit of a delayed interval there. So maybe a sinus arrhythmia. Okay, the PR interval is the right length. The QRS duration is narrow, so there's no bundle branch block or Barron-C. The QTC looks to be short at 389 milliseconds. That's the second number there. Okay, the QTC. And a shorter QTC kind of helps us differentiate a lot of times. We'll say, well, early repolarization will cause a shorter QT interval because the T wave itself is repolarization. So if you have a short QT, so if you look here at V3, there's the Q wave, there's the end of the T, and if you were to think that this T wave here has to come earlier, your QT interval is going to shorten. So we say that early repolarization may have a shorter QT interval, and usually anterior MIs tend to have longer QT intervals. So it's good to use that to help differentiate. Then our axis, our QRS axis, is 54, which is normal, and you can quickly just double check to make sure. If all of these leads right here, 1, 2, and 3, are positive, that's a quick indicator that your QRS axis is normal. Or you can use the quadrant method, where you would look at lead 1 and AVF. I'm just going to quickly do it here. Lead 1, AVF. And lead 1 is positive, so you'd shade out the negative side of lead 1. AVF is positive, so you'd shade out the negative side of AVF. And then this is the normal quadrant right there. If you don't know or understand that, at the end of this case review here, you'll see a little video link in the bottom right for the ECG axis tutorial that I've done, and you can go ahead and watch that if you're interested. So let's start looking for other stuff, okay? So we've got the rhythm down, all our intervals look okay, and we do obviously see some ST changes. We see lots of ST elevation, and we have it here in V3. I mean, there's a lot in V3 there. This is a lot in V2 right here. I mean, compared to the QRS complex, the size of that QRS complex is pretty small, right? Oops, I didn't mean to change colors there. The size of that QRS complex is pretty small in V2, so that amount of ST elevation is significant. Also, the R wave in lead V2 is kind of early. I mean, it's a little bit tall for that entire QRS complex being small. That's a pretty big R wave. That's not typically normal. We also see the ST elevation in V4, a little bit in V5, not a whole lot in V6. Over here in lead 2, I see some in the inferior leads. There is some in lead 3. You have to take that into account because that also has a small QRS complex, and AVF. So in the sense of acute pericarditis, we've said before that it's global. It doesn't have to be in every single lead. A lot of times V1 will actually have ST depression, but you do have ST elevation in a lot of leads that don't really go along with each other. All right, and all of the ST elevation is concave, So if you were to draw a line like I did there in V4 from the J point to the peak of the T wave, the ST segment falls below that line. That means it's concave, which is generally not as bad, but it can still be bad. So you have to look for other possibilities of an MI. You do have intact R wave progression. If you look at V1 to V6, okay, your R wave kind of progresses as it goes from V1 to V6 with a normal transition between V3 and V4. Okay, that's all normal. Usually an acute MI will cause late R wave progression if it's an anterior wall MI. Okay, and another indicator, you have more ST elevation in lead 2 than in lead 3. So all of these things kind of fit either early repolarization or acute MI. Or acute pericarditis. Early repolarization or acute pericarditis. Except this is, in fact, an acute MI. Let me say it again. This is a STEMI. Now, I gave you all those indicators of why it might be acute pericarditis. This degree of ST elevation in V3 is that actually leans more towards anterior wall MI. These T waves are all tall, and they are symmetrical. Now, it's hard to tell that they're symmetrical, but you have to almost draw a line down and finish off that T wave. And then if you drew a line down the middle, you'd see it does mirror itself on the left and right. So they are symmetrical T waves with a broader base. I wouldn't say that they're hyperacute looking, ish, as they say, but they're not really the big, tall, huge hyperacute T waves that we're used to seeing. But that's not why I would expect this to be a cardiac patient, or a STEMI patient in the field. It would be this. All of this stuff that I told you before the 12 lead. Your acute pericarditis patient may have a recent infection. They might have pain relief when they lean forward. Typically, it's not a 10 out of 10. I guess it could be. But there's other things that go along with it. They kind of fit acute pericarditis. Not so much this cardiac patient. You have to consider the company it keeps. Meaning, don't just look at a 12 lead. Just like they say, treat the patient, not the monitor, when you're in EMT or paramedic school. I'm saying it does hold true. You have to consider your patient's symptoms. Now, if you're worried and you're thinking, well, I don't want to call it a STEMI and activate an expensive cath team based on this 12 lead alone, because this 12 lead really does have a lot of indicators for acute pericarditis. That's fine. Just start your treatment regimen, give them aspirin, give them nitro, and then do consecutive 12 leads. And that's what this crew did. And here's the next 12 lead. The next 12 lead actually looks better than the first, but it's actually resolved pretty much all of the ST elevation, and it in fact says normal up here now. But why is that? Because you gave nitro. Now, if you give nitro to an acute pericarditis patient, I don't think that you're going to have, this pseudo-normalization here of the 12-lead EKG due to the nitrates, due to dilation of the coronary arteries. Now, with an acute MI, you might have some pseudo-normalization, like you see here, because of that increased collateral blood flow from dilating the coronary arteries. Or perhaps the patient just has a critical lesion that hasn't yet totally occluded the coronary artery itself, and when you provide that dilation of the coronary arteries, you're now returning blood flow, eliminating all that ST elevation that we saw before. This is also a good reason you should get a 12-lead EKG prior to providing that first nitro spray or tablet. Okay, so get the aspirin on board. If you want to give them oxygen based on their oxygenation status, go ahead and do that. But get the 12-lead EKG quickly before administering the nitro, because if this was the first EKG you got on this patient, you may not activate a STEMI team. You may just say, okay, the chest pains, maybe something else. You might not go to a PCI center. So you're going to end up delaying care because you started treatment before continuing with your assessment. So this was just a good case to present to you, how not all these findings that we've given you to determine STE mimics will really hold true all the time. I didn't put the information from this into Dr. Smith's, if you follow Dr. Smith's blog, for early repolarization versus anterior MI. He does use the amplitude of ST elevation in V3, and I have a feeling that that amount right there would probably lean us towards an acute MI. Okay, it would be pretty close though with the intact R wave progression. You have very tall R waves in V4. You have a very short QT interval. I mean, all of that does lean towards earlier polarization, but this is in fact a STEMI, okay? And we found out by doing consecutive 12 leads. And I mean, look at the times here. That's why I left the time on here. This one was at 7:25. This is the second one. And the first one was at 7:04. Okay, so that isn't a big amount of time, but I believe that there were a couple in between these. I said this is the second one, but I think there was another one in between this that was much earlier that looked a lot like this second one here. And it was, within a few minutes after the first one, after they gave the nitro. All right. So if you're interested in the angiogram that goes along with this patient, because you don't believe me and you think it was an acute pericarditis, here on the left you see the angio from the initial pre-treatment catheterization, and you'll see that this is your left anterior descending artery, and it is very stenosed. Okay, and you do have some blood flow right here still to that coronary artery, but that might be because the patient's currently on nitrates. That could have been completely occluded with that first 12-lead EKG. And then after treatment, you'll see that stenosis is now gone, and the patient has returned blood flow to that very large LAD. Okay, and it can happen where you have ST elevation in the inferior leads from an LAD or a circumflex occlusion, and you just got to think that not everybody's vasculature is the same. Okay, the body does not read the textbooks, and your blood vessels on your heart are going to be different than your brothers or your sisters or anybody else out there. It's almost like a fingerprint. Okay, now typically we kind of generalize and we'll say that the inferior wall is usually fed by the right coronary artery and the anterior wall is usually the left anterior descending, but things can be different. Okay, so this kind of proves to you that you can have ST elevation and leads that don't really correspond with each other. Now, something I wanted to start doing is give you guys an EKG resource to continue your education. A lot of people ask me good places to get good information, and I've talked about this place a lot, EMS12lead.com. Tom Bouthillet started it. He now has a couple other people publishing information on there. Christopher Watford puts a lot of good stuff on there. He's always commenting on the Paramedicine101 site as well. So I had to give him a little plug there. Go to EMS12lead.com. Look at all the old cases. By the time you're done, you'll be an EKG ninja. You will definitely learn a lot. Send me an email if you have any questions or if you have any cool cases that you want to talk about, any 12 leads you want to ask about. I love getting that stuff, and I will respond to you. So go ahead and send me an email and keep watching these videos. I'm Adam Thompson, and I will see you next time.